So with that, the webinar today makes me think about a paper we published in 2012 on a variety of wellness companies doing well steps, where we were able to document pretty dramatic increases in physical activity, not just at 1 year and 2 years, but very solid improvements in health behaviors. We're able to show clinically important decreases in elevated health risks like diastolic blood pressure. This paper is in press right now with Population Health Management, and changes in cholesterol. So we've been really excited to see these, what I consider very significant changes in individual employee health. And these are groups of thousands of individuals who have improved their health. Then we've got a study with Salt Lake County where we looked at their changes in healthcare costs between participants and non-participants across time. This is a group, a public entity, a WellSteps client that has saved $3.3 million in claims. So we've been busy doing these studies. And then, not long ago, I saw this quote: "Yes, every single wellness outcome which has been public is made up." Or 90% of wellness programs being sold to companies are counterproductive at best, at worst, and worthless at best, which is making me wonder, there's a huge disconnect here. And there's a lot of confusion out there, obviously, in the market, because we have been publishing, and Ron has been publishing, extremely good studies on the impact of these programs. And yet we see quotes like this making it into the media, making it into the blogs. It suggests that perhaps there are a lot of people out there who are manufacturing uncertainty to accomplish personal gains. And this is just patent falsehoods. So with that information, I want to go ahead and toss the bar over to Dr. Goetzel. Ron understands this issue and has been defending us more than anybody else. And I want to make sure you get a full view of what Ron is doing. He understands this better than anybody, and you need to get ready and put your seatbelt on, because we just entered graduate school. Ron, thanks for joining us, and we'll turn it over to you.
Thank you very much, Steve, and thank you all for being the audience for this session. I think it's vitally important that we clear the air and try to get some of the information out there. Now, the intent is not to be confrontational or use incendiary language, but really for us to continue a rational discussion, avoid any provocative terms or innuendo and all that, but really through civil dialogue, elevate the field and make sure that we're doing what is needed in order to document program success. And in fact, if you look at corporate research, you will find that these are the generic limitations of conducting this kind of work. There's self-selection bias, there's attrition, treatment fidelity problems, instrumentation, maturation. Maturation is when people get older. That in and of itself affects their health risk profile and their cost profile. History, other things going on in the environment. Publication bias. There's absolutely no question that the studies that get published are the ones most likely to have positive results, because there aren't as many studies out there that are funded by independent sources like the federal government. So these are generic limitations that are found in real-world research. There are also other external validity problems related to generalizability of results. And let me just step back for a moment and review for the audience research methods or study design 101, kind of the basic categories of conducting research. There are three broad categories. There's pre-experimental studies, quasi-experimental studies, and true experimental studies. And as noted here with the arrow, the validity of the results increases as you move down the list from pre-experimental down to true experimental. And I'm going to show a little bit of notation here in the following few slides. X refers to the intervention or the program, the wellness program, and O refers to the observation or the point in which data collection occurs. So the ideal state is an experimental design, and this is the kind of research that's done in the medical sciences with pharmaceuticals and different treatment options, where essentially you've got a pool of people and you randomly assign them to treatment or control conditions. So whatever other innate characteristics may be causing them to behave a certain way, they're randomly distributed across the treatment and control group. So this is the ideal scenario, but unfortunately in our world, in the corporate world, we don't have many opportunities to randomly assign people into a wellness program versus a non-wellness program. So what's the other extreme? The other extreme is something called pre-experimental design. The most common usage of that is called a one-group post-test only, where you have an intervention program and then you ask people afterwards, what did you think of the program? Now, a slightly better design, but still pre-experimental, is a one-group before and after. So you take measurements at the beginning, you have the intervention program, and then you make a measurement along the way at some time later. Sometimes you collect a lot of baseline data, you collect a lot of follow-up data, it's longitudinal, so that's a little bit better. However, here's what may happen if you've got a pre-experimental design. So you've got 2 data points in time. You've got a base year and a follow-up year, and let's say you're looking at healthcare costs, and the costs are going down, and you say, well, that looks pretty good. However, what if those 2 data points are really part of a longer-term trend? In other words, these healthcare costs were going down anyway, and you just happen to pick 2 points in time to measure things, and it turns out that things were going down, but is it truly as a result of the intervention program? So the main problem with using a pre-experimental design, a pre-post design, is that you get an answer, but it's a simple answer, and you're basically saying that because I collect data before the intervention and after the intervention, the savings that I realize are as a result of that intervention. So there are 2 main problems. One is self-selection bias, and the other is regression to the mean. And this is what regression to the mean looks like. And this slide is taken from researchers at the University of Michigan Health Management Research Center, Shirley Musich. And what it shows is 3 lines, and essentially looking at, on a quarter-by-quarter basis, at healthcare costs for 3 different populations. At the bottom, you've got people with no disease, and their line is pretty flat. In the middle, in the green line, you've got people with some minor disease, and you see a little bit of a blip over time. And the top line, the yellow line, is people with serious disease, and there's a sharp incline in their costs, and then all of a sudden it precipitously drops. Now, what happens at the peak there? What happens is that people are hospitalized, they go to the emergency room, there's some kind of acute event that triggers that very dramatic rise in costs. Now, what's interesting about this slide is that this is a natural flow of costs for this population without any intervention program, and essentially dramatically illustrates this notion of regression to the mean, that even if you do nothing at all, your costs and some of the other measures are going to be dropping back to their normal levels, even with no intervention. So how do you address these concerns, these internal validity issues? What we do is something called a quasi-experimental design, where you've got a pre-test and post-test, but you've got a comparison group as well. And what you try to do is find as many people in the comparison group as are in the treatment group, and you match them up as closely as possible. So even though they're not randomly assigned to treatment and control group, you are following 2 populations over time, and you're trying to control for self-selection bias and regression to the mean. So how do you do this? There are a variety of techniques that are out there. One that we commonly use is called propensity score matching, where essentially what you're trying to do is find a twin of the person in the intervention group. And you match them across demographic variables, regional variables, cost variables, disease severity variables. But at the beginning, you have essentially have a person who's in the intervention group who's exposed to the program, and another person in a comparison group who's not exposed to the program, and then you follow them over time to see if there are differences in their utilization and health patterns. Now, stepping back from design issues, let's examine the evidence out there in terms of workplace health promotion programs. Do they work or not? Now, there was a systematic review conducted by the Community Guide. The Community Guide is a group of independent, non-compensated individuals. I'm a member of the Community Guide Task Force who are housed at the CDC. So their CDC has a whole group of people who work on the Community Guide Task Force who do systematic reviews of literature, and they conducted this systematic review of the literature, published the review in the American Journal of Preventive Medicine, here are the people who are on the Community Guide Task Force staff. These are the folks who organized and arranged and facilitated the review that was published. So this is the review published in AJPM in 2010, and these are the authors. And you can see it's a long list and very respectable list of people who were involved in that systematic review. What did that review reveal? So it looked at behavioral risk factors, it looked at biometric risk factors, and it looked at also financial outcomes from worksite health promotion programs. Now, they started off with thousands of studies, but because they have very strict criteria as to the kinds of studies that satisfy the requirements of a systematic review, they ended up with just a handful of studies, and that's called a body of evidence, in order to evaluate that body of evidence. So they're looking at each risk factor, the outcome on the left, the number of studies that were relevant and useful and applied good methods as the body of evidence, whether the results are consistent in all those studies, what the magnitude of effect is, and whether there's a conclusion made by the task force that there is sufficient, insufficient, or strong evidence that these programs have an impact. So if you can see, looking at this table here, these are behavioral risk factors, and the Community Guide Task Force found that there was sufficient or strong evidence that worksite programs can influence alcohol use, percent fat intake in the diet, physical activity, tobacco use, seatbelt non-use. Looking at biometric outcomes, there is strong evidence that these programs can have a positive influence on blood pressure and cholesterol. The jury is still out on BMI and fitness. And they also concluded that there was sufficient or strong evidence that these programs can have an overall population health impact, that they can influence healthcare use and workforce productivity. And you can see that there are a number of studies that show that there are consistent results and moderate effects at the very least. What about ROI? Of course, there's a lot of debate about return on investment and whether these programs actually pay for themselves, which, by the way, is not a requirement for everything else that's done in healthcare. So when somebody goes in to have a coronary bypass procedure performed, no one asks at the end of that procedure, what's the return on investment? How much money do I get back from that procedure? Really, most everything done in healthcare is a cost. The true question ought to be, is it cost effective to do that kind of intervention? In the case of workplace health promotion programs, in order to achieve or realize financial ROI, you need to get awareness increases in the population. People need to know how to adopt healthy lifestyle and healthy habits. They need to participate in these programs. They need to increase their knowledge about good health habits, improve their attitudes, change their behavior, reduce their risks, reduce their utilization of healthcare services or other productivity-related corporate services. And if they do all those things right, and yes, if they measure those things along the way, there's a good possibility that the program will actually produce a positive return on investment. What about the evidence on ROI? Well, this is another literature review that was conducted by 3 Harvard economists, Baker, Cutler, and Song, who are not involved in evaluations of workplace health promotion programs. So essentially, they're independent, outside objective reviewers of the evidence. And their study, published in Health Affairs in 2010, came with the headline, Workplace Wellness Programs Can Generate Savings. Their analysis, similar to what the Community Guide did, was look at the studies that looked at health outcomes and financial outcomes, most notably healthcare utilization and cost outcomes and absenteeism outcomes. They sliced and diced the data in various ways, and then based upon their analysis came up with an overall conclusion that in terms of medical care cost savings, roughly a 3-to-1 ROI was calculated across the various studies, and a similar, somewhere around a 3-to-1 ROI evident in terms of reductions in absenteeism. Let's briefly review some case studies that we've been involved in. An earlier study that was conducted in the 1990s, actually, was with Citibank. And this was one of the earlier health management programs that was introduced. 2 separate studies were published in peer-reviewed journals looking at the impact of risk reduction in the population of Citibank employees and also cost savings and return on investment. This analysis followed about 9,000 Citibank employees over a 2-year time horizon, looked at 11 risk factors, and looked at the net changes in the risk profile of the population at baseline and then 2 years later. And as you can see, there's a net improvement in 8 out of the 11 risk factors, although the risk changes were not dramatic. There's a 1, 2, 3, perhaps 4 percentage point net improvement in the risk profile of the population. However, it turned out that if you're able to move the population even a small amount, that actually does generate cost savings as much as $150 approximately for those lucky individuals able to show a net reduction in the risk profile over the 2-year time horizon. And looking at the participants and non-participants in the Citibank program, and this is over a 38-month time horizon, about 23,000 people involved in this study looking at their claims data, we found that if you do the math, roughly an $8.9 million savings, which compared favorably with a $1.9 million investment in the program, generating a net benefit of $7 million, and in this case, a very, very high 4.7 to 1 ROI. That is $4.70 saved for every dollar invested. Another study with Procter & Gamble. This is Cincinnati, Ohio headquarters, employs about 8,000 people, about 4,000 involved in the health promotion program, 4,000 not. We looked at them at baseline. They were about the same cost in terms of total expenditures at baseline, but after 3 years, in year 3, a 29% difference in total medical costs. And we also isolated out, specifically identified ICD-9, which are diagnosis codes that are thought to be influenced by health behaviors and lifestyle. And we found that there was an even more dramatic difference in terms of lifestyle-related diagnoses between participants and non-participants after 3 years, roughly a 36% difference in lifestyle-related diagnosis codes. Another study we conducted was with Highmark, and this is a health plan located in Western Pennsylvania with about 12,000 workers. Highmark introduced a very robust, comprehensive workplace health promotion program. They did health risk assessments, they had online programs, they had tobacco cessation, on-site nutrition and stress classes, individual coaching and counseling, biometric screenings, campaigns, and they erected 2 fitness centers. So a very comprehensive health promotion program introduced. They had a very, very high participation rate in the program. Roughly 10,000 out of the 12,000 employees participated. And so what we had to do was to find non-participants who were not exposed to the program and match them up to the participants using the technique that I mentioned earlier, propensity score matching. And we matched them up in terms of demographics, baseline expenditures, whether they had certain diseases or not, severity of their disease. We also went outside of Highmark because we couldn't find enough matched subjects, and we went into the book of business and found organizations that were similar to Highmark in terms of the industry that they were in and found matches to them. And as you can see in this chart, there were no statistically significant differences between participants and non-participants at baseline. And then we tracked them over several years. So there was a baseline period, there was a program intervention period that started, and then after 3 years of exposure, you can see that there was a difference in terms of their total annual healthcare expenditures between participants and non-participants. That difference, after you control for the confounders, turned out to be $176.47. And when you put this all into a large spreadsheet and you look at all the costs of the program, which is at the top of the spreadsheet, look at the savings, you see that the cost of the program were about $800,000, savings about $1.3 million. So the net difference between costs and savings about $500,000, and in this case, a return on investment calculated to be $1.65 for every dollar invested. Let's turn to another case study. This is with Johnson & Johnson. Johnson & Johnson was one of the pioneers in workplace health promotion programs, introducing the Live for Life program in the 1970s. And they have spent a lot of time, a lot of effort, a lot of money actually evaluating their programs over the past 30 some odd years. And this is the latest evaluation that was conducted, that was published in Health Affairs in 2011. Rachel Henke, the lead author on this study. Here again, what we did was we matched the Johnson & Johnson population to our MarketScan normative group. This is comprised of large companies, similar industries as Johnson & Johnson blinded. And then we looked at their biometric risk factors, J&J versus the MarketScan norm. We can see that J&J is doing better in blood pressure and BMI. They're not going up as fast as the MarketScan group, but they're actually at pretty low levels, average BMI rates of about 20% for the population. They're also doing better in terms of eating habits, physical activity, and tobacco use. In fact, in tobacco use, they're below 5% of the population using tobacco products. Two areas where they were not as good as the MarketScan norm were in depression and stress, the two psychosocial domains were analyzed, and that indicated to J&J that they need to pay more attention to those risk factors if they want to bring them down to at least the normative values. Now, going back to the techniques that are used in quasi-experimental designs, this is a table that is taken from the Health Affairs article that shows how the J&J employees were matched using propensity score methods to the MarketScan norm. So we have about 32,000 J&J employees. We started off with about 470,000 in the normative database, but after we do the matching, it turns out that they are actually very, very similar in terms of the demographic characteristics, disease severity, plan type, exposure period, of several other variables to the normative group. And then in this case, what we're able to do is track their healthcare utilization and cost metrics. This is looking at their medical trend from 2002 to 2008. After inflation adjustment, we see that the J&J healthcare costs were going up at about 1 percentage point a year versus the MarketScan group at 4.8 percentage points a year during that time period. So about a 3.7, 3.8 percentage point difference. That translated to about $565 of savings per employee per year, and an estimated ROI that ranged from $1.88 to $3.92 to 1. One other case study of interest. This was just recently published in Journal of Occupational Environmental Medicine, and this is with Vanderbilt University employees. And what's remarkable about this is Vanderbilt University has been collecting health risk data on its population now for 10 years. This is a study that tracked the population over an 8-year time period. Now, these are employees of Vanderbilt University who have access to the wellness program there. And what this study did was look at whether employees of Vanderbilt, if they're able to change their risk profile, whether that has an impact on diabetes incidence. So we're actually looking at participation in the program and change in the health risk profile of the population and whether that can influence a specific disease outcome, in this case diabetes. So in this table, what we're looking at is obesity. And we're looking at populations that keep their risk factor, lose their risk factor, maintain a healthy habit, or lose that healthy habit. So looking at this very quickly, people who were obese in year 1 remained obese in years 2 to 4. Then we're looking at their incidence of diabetes in years 5 to 8, and 10% of that population had an incidence of diabetes in the latter years, essentially developed diabetes. For people who lost their risk factor, went from obese to non-obese, the incidence rate was 2.4%. For people who were not obese in the baseline period, 1.2% developed diabetes, and people who were not obese but became obese, their incidence of diabetes was 9.4%. So they were actually very similar to the population that remained obese. So here we're seeing a direct relationship between a workplace program, changes in the risk profile of that population, and its direct effect on one specific disease outcome, in this case diabetes, over a long time horizon, over 8 years. Let me turn our attention now to the RAND report, because there's been a lot of discussion about the RAND report and what it actually says. Now, for all of these slides that are coming up, I have not altered any of the slides. I essentially have just taken pictures from the RAND report itself. So I've not manipulated any data. In fact, I've not manipulated anything from the report. I'm showing you the actual data, and I'll then comment as we go through it. So here are the results from the RAND report in terms of looking at the impact on health risk-related behaviors and health status. And we're focusing specifically on something called the CCA database, and I'll get to that in a moment. Basically what this says is that when comparing wellness program participants to statistically matched non-participants using similar methods that I described earlier, propensity score matching, we find statistically significant and clinically meaningful improvements in exercise frequency, smoking behavior, and weight control, but not cholesterol control. And these improvements are sustainable over an observation period of 4 years. And we see cumulative effects with ongoing program participation. Okay. In terms of healthcare costs and utilization, down at the bottom, we say our statistical analysis suggests that participation in a wellness program over 5 years is associated with a trend towards lower healthcare costs and decreasing healthcare usage. We estimate the average annual difference to be $157, but the change is not statistically significant. Now, let's see how the report was picked up by the media and interpreted by the media. So this is how Sharon Begley from Thomson Reuters presented the results of the report. She said, long-awaited report on workplace wellness programs delivers a blow to the increasingly popular efforts Reuters has learned, casting doubt on a pillar of Affordable Care Act and the favorite of the business community. According to the researchers, programs that try to get employees to become healthier and reduce their medical costs have only a modest effect. These findings run contrary to claims by mostly small firms that sell workplace programs to companies. The RAND report was commissioned by the U.S. Department of Labor, Department of Health and Human Services. The report found that people who participate in such programs lose an average of only 1 pound a year for 3 years. Cholesterol levels were unaffected. Some evidence of smoking cessation programs work, but they only do so in the short term. And they said that the workers participated in the wellness program had healthcare costs averaging $2.38 less per month than non-participants, and $3.46 less in the 5th year. Modest savings were not statistically significant, could have been due to chance. Just another example of the media coverage. This is from the Omaha World Herald, July 15. The RAND Corporation report released in May concluded the wellness programs can improve health, but barely pay for themselves in the short term. The RAND study looked at 600,000 employees and their dependents, 7 employers, found that participating in the program was associated with annual healthcare savings of $157 per person, while the annual cost of the program averaged $150 per person. And again, not a very positive portrayal of the RAND results. But let's look at the data. First of all, there are some concerns about the sample sizes that were used in the study. I should point out that we, being Truven Health Analytics and Emory University, prepared the database for RAND Corporation to use through a contract with CCA, which CCA stands for Care Continuum Alliance. Now, we gave RAND Corporation a very large database. In fact, they report that the database included 567,000 unique employees and 1.8 million employee years. What this table shows is how that breakdown comes down in terms of after you apply various inclusion and exclusion criteria, you still end up with about 288,000 people who you could analyze in terms of healthcare costs and utilization trends. For the HRA database, there are 173,000 people available for health risk assessment analysis. About 150,000 where BMI data are available, 66,000 cholesterol data available, 59,000 for exercise data available, and smoking data available for about 61,000. Now, I point to these numbers simply because, as you see from my follow-up slides, far fewer people were actually involved in the analyses produced by RAND. So, for example, in weight reduction results involved 3,924 people, and what this chart shows is, as reported, about a 1 pound reduction between participants and non-participants in the program. Now, these are statistically significant across the 3 years, but 1 pound doesn't sound like a whole lot. But look at these other results that were included in the report. What we have here is the proportion of the ratio of people who are normal weight, overweight, and obese. You can see that for participants, the normal weight group goes from 21% in 2005 to 33% in 2010, versus the non-participants that goes from 21% in 2005 down to 19% in 10. The obese group on top goes from 36% to 27% for the participants, and increases from 36 to 40% for non-participants. So if you do the math, this is about a 14 percentage point swing in obesity rates, which, to be honest, if we found those kinds of results, they would be outstanding, and they'd be actually not believable because they're so dramatic, they're so good. So these results don't really conform to the prior results related to the average of 1 pound lost. Here are the weight results presented graphically for males and females, and you can see the red is the participant group, their weight is going down, the non-participant group is holding steady. Smoking results, this is 746 people out of the pool of people we saw earlier, which was much higher than that, about 60,000 people. But here again, we're seeing statistically significant reductions in smoking rates as high as 30%, participants versus non-participants. And again, these results would be extraordinarily dramatic if we were to find them in the typical health promotion program. So these are quite large changes and improvements in smoking rates for this population. Exercise results showing dramatic improvements, statistically significant improvements in exercise rates in first year and then second year. Here are the results graphically for exercise showing participants and non-participants, where the participants are increasing their exercise rates. Cholesterol results, yes, no statistically significant differences in that population, but again, look at the N, 1,341 people that were analyzed for cholesterol. And here are the cholesterol results. Now, healthcare costs, we're looking at 12,000 people who were tracked for this healthcare cost analysis. As noted earlier, there are several 100,000 people who are included in the claims database. So it's a question as to how come only 12,000 people were analyzed. But here you can see actually graphically quite a dramatic difference between participants and non-participants. Again, participants are in orange. Their healthcare costs are evening out, they're straightening out, whereas non-participant costs continue to increase. One thing I don't quite understand is why the confidence intervals are so narrow for the non-participants and they're so wide for the participant groups, if indeed these individuals were matched at baseline. Here are the admission results. Again, we're seeing dramatic reductions in admissions for participants compared to non-participants. We're seeing reductions in emergency room visits for participants and non-participants. Now, a whole host of questions have emerged from the RAND study. In fact, CCA, the Care Continuum Alliance, has posted all these questions to the researchers from RAND Corporation. They're available at this website. I'm anxious to see what some of the responses are to some of those questions. Let me turn attention now to the other debate that's out there that has to do with incentive programs. And the question that's being posed is whether these incentive programs are discriminatory in nature. And this is an article that was in Health Affairs by Horowitz, Kelly, and DiNardo that basically said that wellness incentive programs basically shift costs to unhealthy workers, and they are discriminatory. Now, as an example from their article, they quoted the study that we published called the HERO 2 study, which found that, as it shows here, that controlling for multiple risk factors had a large influence on results, true. Without these adjustments, the evidence showed that people with high cholesterol spend more than people with low cholesterol, and that's, by the way, not true. It also found negative or non-significant results for these other two risk factors, excessive alcohol consumption and poor nutrition. And indeed, this is a table from the HERO study which does show that cholesterol, nutrition, and alcohol consumption actually did not have a statistically significant effect on cost. But the 7 other risk factors above those 3 did have a statistically significant effect on cost, and those data were omitted from the analysis. So I wrote a response to the Horowitz et al. Paper. It's posted on the Health Affairs website. DiNardo, one of the authors, responded to my response, and then most recently in the last week, I've had a response back to the DiNardo response. So for people interested in this discussion debate, I refer you to the Health Affairs blog, which is available for free, by the way, to follow this progression of discussion, which, by the way, I find to be very, very helpful because it keeps everybody ethical, honest, and legal in the way in which these incentive programs are being structured. Let me end with a discussion of the Health Project and some of the attacks that have been foisted against the Health Project. The Health Project is an organization that's been in place for the last 20 years. The late Dr. C. Everett Koop was the honorary chairperson of the Health Project. Each year for the last 20 years, the Health Project has been awarding its Koop Awards to those organizations that are able to document health improvement and cost savings as a result of their workplace health promotion programs. I am the president and CEO of the Health Project. Chairman and co-founder is Carson Beadle. Seth Serksner is vice president. Jim Fries from Stanford University is chief science officer, and Jim Wheel is our secretary. And here is a list of all the board members. And Steve Aldana is listed above because alphabetically he comes first, but you can see that this is a very impressive list of researchers and practitioners who are involved in workplace health promotion and the wellness programs. The way in which awards are conferred is that each application from companies that submit these applications is reviewed independently. They are reviewed, critiqued, and scored. We compile the scores, we have a discussion, we have a vote, and at the end of that, we decide who the winner of the Koop Award should be that year. Oftentimes, we get many applications, and the awardees are usually 1, 2, or 3 awards in any given year. In fact, this year, we only have 1 Koop Award. For the data that we used in evaluating the state of the Nebraska application, this looks at the changes in a cohort population over time at baseline and then follow-up in terms of various risk factors. Now, not all of the risk factors are going in the positive direction, but many of the risk factors are going in a positive direction, and there's statistically significant improvements in the risk profile, population health risk profile for the state of Nebraska. There's also financial analysis that was prepared for the application, which used best methods, including propensity score matching, in conducting that analysis and estimating cost savings and an ROI. Part of the application included the data on preventive screenings. And as you can see from this chart, actually it's not that easy to see, but the rate of increase in preventive screening was enhanced in each of these categories. So let me return to where I started, which was Research Design Basics 101, and look at the different levels of evidence that are out there in order to determine whether something is effective or ineffective. And this is a rating scale that's used universally in terms of looking at the rigor of research studies. So an A grade is given to properly designed randomized controlled studies, experimental designs. A B to well-designed controlled studies without randomization, quasi-experimental designs. A C to well-designed cohort or case control studies. A D to pre-experimental studies, either multiple time series studies, correlational regression studies, but typically where there's no comparison or control group. And then an E grade is given to expert opinions, descriptive studies, case reports, reports of expert community.
I have a couple of questions right up front, and I know we've got Troy on the back end doing some other ones. But my first question was, why do you think there is the level of criticism towards the whole wellness research area now? I mean, we haven't had this level of criticism for a long time, and now we've got it from several sources. What do you think is the reason behind that?
I think there are several factors. One is the Affordable Care Act and what that has inspired. Of course, the Affordable Care Act is called Obamacare by many people, so it plays into the political divide we have in this country between Republicans and Democrats, quite honestly, where one group is firmly opposed to the Affordable Care Act and another group is supportive of that. And there's a spillover effect, I think, into provisions of the Affordable Care Act. And provisions were put into the Affordable Care Act to increase prevention and health promotion. Some are in the Medicare program, some are in terms of the benefit plan design issues, and some are specifically directed at employer initiatives that are designed to improve the health and well-being of the population. So that may be one angle or one hook that has been focused on in terms of this is a bad thing for the country, Obamacare, and this is a provision of Obamacare which is bad. It also, there's some rules and regulations that have changed, especially as they relate to incentives and the design of those incentives. And I think that has brought out the legal community in terms of potential discrimination that may be associated with that. And then thirdly, I think there's just opportunity here for groups to create controversy and to create a business that may involve litigation or may involve selling consulting services.
What really reminded me when we had the big tobacco push in this country, where we had the industry fighting against the scientists, declaring tobacco use to be dangerous, we see where they have manufactured uncertainty in the research, claiming there were not clinical trials, the famous Senate hearings where all of the leaders of the tobacco industry claim, I do not believe that tobacco is addictive or is harmful. They created an artificial uncertainty regarding the science. It happened in the tobacco industry. It's currently happening with climate change in this country right now, where we have the majority of scientists who are now being criticized because of the lack of science. And I see this attack as almost being identical to those, where they manufacture uncertainty so as to create an element of doubt for whatever their political or personal gains are. Is that a correct observation?
Yeah, I think there are people who have stakes in the industry, a variety of stakes that want to see certain positions upheld. And certainly, again, the legal field, is looking for opportunities to challenge laws, to challenge provisions, and to challenge various actions. So, people are jumping at opportunities. Most people are looking for good opportunities to improve health and healthcare delivery in this country, and I think there's a great deal of productive innovation that's going on to improve the way in which healthcare is being delivered and prevention is being delivered. But there'll always be people who are looking for other angles and other ways to take advantage of the changes that are forthcoming.
We have a lot of brokers and consultants who are on the call today. And what would you like them to take away from this presentation? From all of this discussion today, there's been a lot of market confusion. Some people are second guessing their desires to help employers do wellness. If you could summarize for them what the important takeaway of all this is, what would that be?
Well, I think, first of all, you cannot judge a category in one fell swoop. You can't say that health promotion or wellness programs are good or they work or they are bad and they don't work. In my experience, there are some programs that are exemplary, they're excellent, they work very, very well, and I'll explain why they do. And there are a lot of other programs that work very, very poorly, are there on the surface. They really do not have any impact on behavior and change because they're not resourced properly, they don't have leadership commitment, the environmental and ecological and policy framework is not there to support a healthy lifestyle. So there are many examples out there of poorly structured, poorly delivered programs that absolutely do not work, and I agree that there are lots of claims made about those programs that are false. And so there ought to be an ongoing bright light being shining on these types of programs to make sure that they are effective. They are, on the other hand, there are programs that are very well designed, well implemented, well resourced, with a lot of support from the organization that puts them in place, those programs do work. Back to the idea of throwing out the baby with the bathwater, let's separate out those programs that do work from those that don't work and encourage the adoption of effective and evidence-based programs.